Namaskar. Today we will study anticoagulants. And anticoagulants are the drugs which modify the coagulation cascade when there is a defect in coagulation or when there is excess coagulation or unwanted coagulation. In that case, we can use anticoagulants. So blood coagulation occurs in three steps. The step one is prothrombinase formation, which differs in intrinsic pathway and extrinsic pathway. And after prothrombinase formation, this second step is formation of thrombin. Third step is formation of clot from the fibrinogen. So anticoagulants will modify this coagulation cascade. So it can be classified into natural. The natural anticoagulant is the antithrombin 3, AT3, and heparin. And in protein C is there, and protein C is a plasma protein which inactivates factor 5 and factor 8. Factor 5 and factor 8 are inactivated by this protein C. And prostacyclin or prostaglandin I2 actually inhibits platelet aggregation. So it is there, but we'll specify to this antithrombin 3 and heparin. So injectable anticoagulants, we can classify them as AT3 dependent and AT3 independent. AT3 dependent will include heparin, low molecular weight heparin, heparinoids like heparin sulfate, dermatan sulfate, dextran sulfate, ancrod, etc. Then AT3 independent, hirudin, hirugen, hirulog, all these hirudin fragments, and these are all the leach products. Then compete for active site of thrombin, and they are argatroban, inogatron, naprogatron, melagatron, all these things. And they compete for the active sites of thrombin. So they are AT3 independent. Then we have oral anticoagulants like coumarin derivatives like warfarin, dicumaril, and indendione derivatives like phenandione, anisindione. All these things, all these drugs are anticoagulants. So you can see this heparin is a large polymer with molecular weight about 750,000, and this can be used intravenously or subcutaneously, and they do not cross blood-brain barrier or placenta. So they are the drug of choice in pregnancy, heparin. And low molecular weight heparin, they are the heparin fragments with molecular weight only 4,000 to 15,000. They are used subcutaneously. Then let us understand all these mechanism of heparin and low molecular heparin through these diagrams. So we have antithrombin 3, which has two sites. One is heparin binding site, and the other is the thrombin binding site or factor 10 binding site. So to this site either thrombin will bind or factor 10 will bind, and another site is for binding of heparin. Then we have thrombin. Thrombin has two sites. One site for AT3 antithrombin 3 binding site, and the other site is for heparin binding site. So heparin has two sites. One is AT3 binding site, and the other is thrombin binding site. But this factor 10 has only one site, AT3 binding site, and there is low molecular heparin which has only AT3 binding site. Okay, so now that means from this structure we can say that heparin binds to antithrombin 3 and accelerates its action. So heparin binds to antithrombin 3 and accelerates its action. What is its action? Antithrombin 3 inhibits thrombin. So the antithrombin 3 inhibits thrombin. Heparin binds to both antithrombin 3 and thrombin and accelerates the action of antithrombin 3. But to inhibit that means to inhibit the thrombin, heparin has to bind both AT3 and thrombin, whereas to inhibit factor 10, it has to bind only AT3. So AT3 inhibits factor 10, and heparin binds to AT3 to facilitate the action of antithrombin 3. So to inhibit thrombin, heparin has to bind both 83 and thrombin. To inhibit factor 10, heparin has to bind only 83 because factor 10 has no site for heparin. So low molecular weight heparins actually inhibit factor 10 because low molecular weight heparin has only site for 83. So 83 inhibits factor 10, low molecular weight heparin binds to 83 and increase the action of 83 on factor 10. Okay, but low molecular heparin has no action on thrombin inhibiting action of 83 because it has only one site to bind to 83. To inhibit thrombin, it has to heparin can only bind because heparin has site to bind with thrombin. So if there is heparin excess, then we can use heparin antagonist like prothrombin sulfate. Prothrombin sulfate is the low molecular weight protein isolated from fish sorb, and it can be used in cardiac surgery and other vascular procedures. And heparin action can be neutralized by heparin neutralizing protein called platelet factor 4. So platelet factor 4 neutralizes the action of heparin, but low molecular weight heparins are not neutralized by platelet factor 4. So this heparin can be used as anticoagulant, and in higher dose they can increase or prolong the bleeding time, and they have another action. They release lipoprotein lipase, which will hydrolyze the triglycerides of chylomicron and very low density lipoprotein. So the plasma looks clear because of heparin. Now we will discuss the oral anticoagulants, and oral anticoagulants like warfarin. So the vitamin K, we can see here this vitamin K acts as the coenzyme to the enzyme gamma carboxylase in the synthesis of 4 factors, factor 2, 7, 9 and 10, which are all glycoproteins. In final step of their synthesis, there is gamma carboxylation, and enzyme is gamma carboxylase, and vitamin K acts as the coenzyme to this enzyme. So the active form of vitamin K is KH2 or hydroquinone. This hydroquinone is converted to the inactive form epoxide. So this epoxide form is again regenerated, means regenerate the active form hydroquinone by reduction. The enzyme is vitamin K reductase, K0 reductase and K reductase. So warfarin inhibits this reduction, inhibits the vitamin K reductase, and by inhibiting vitamin K reductase, it inhibits the regeneration of the inactive epoxide form to the active hydroquinone form. So this reduction is inhibited, so there will be no regeneration of the active form of the vitamin K, so there will be no gamma carboxylation, no synthesis of these factors, factor 2, 7, 9 and 10, and because of that there will be no blood coagulation. So they in this way these oral anticoagulant like warfarin act, and they have adverse effects like hemorrhage, teratogenicity, hepatotoxicity, necrosis of soft tissues of breast, buttock, etc. All these are side effects. And if there will be warfarin poisoning, then we can treat the warfarin poisoning by warfarin antagonist, that is vitamin K. So we can use vitamin K and factor 9 concentrate to act as warfarin antagonist in treatment of warfarin poisoning. Then another concept is their prothrombin time, and this prothrombin time is the time taken for clotting of citrated plasma after addition of calcium and standardized reference thromboplastin. And what is this prothrombin time? This prothrombin time is usually used to monitor the effect of warfarin, and usually expressed as international normalized ratio INR, which is PT ratio to the power ISI. ISI stands for International Sensitivity Index. So PT ratio, it is the ratio of prothrombin time of the patient concerned, prothrombin time of the patient concerned, because it differs from person to person. So prothrombin time of a person to prothrombin time, that is normal prothrombin time, so which is calculated as prothrombin time of a pool of plasma from healthy subjects on no medication. So a pool of plasma will be collected from healthy subjects who are not in any medication, and that will be your normal prothrombin time. Then you have the patient prothrombin time. So patient prothrombin time divided by normal prothrombin time, that is your PT ratio, is to ISI, International Sensitivity Index. And this ISI, because of the variability of thromboplastin or factor 3, so each thromboplastin is assigned one ISI. So based on that INR is equal to PT ratio to the power ISI. In this way it will be calculated. So from this prothrombin time, the effect of warfarin is monitored. So this is all about anticoagulants. Thank you.